In this session, we'll be seeing about verrucous carcinoma. So first of all, we should know about the conventional oral squamous cell carcinoma. So this is a patient, a 45-year-old male patient, the history of tobacco chewing, and we can appreciate the deep necrotic ulcer present in the lateral border of tongue. A biopsy was done, and this is the histopathology showing a breach in the basement membrane, and we can appreciate the epithelial islands seen invading the connective tissue. Also, the cells inside these islands exhibit cellular as well as nuclear pleomorphism, and we can also see numerous keratin pearls within these epithelial islands. So this is a classical clinical and histopathological feature of conventional oral squamous cell carcinoma. So this is another case of a 60-year-old male patient with a growth in the buccal mucosa and in the retromolar pad area region. And this growth has a papillary surface, papillary projections. And when a biopsy was done, we can see that in the histopathology, the epithelium is well differentiated with the increase in the keratinized layer. And we can also see the broad elongated rete ridges, and the basement membrane is found to be intact. And there is intense chronic inflammatory infiltrate in the subjacent connective tissue. So this is a different form of squamous cell carcinoma. It's a variant of the conventional squamous cell carcinoma, and this is called as verrucous carcinoma. So it's a low-grade variant of squamous cell carcinoma, and it was described by Ackermann, so it's called as Ackermann's tumor. And since it's common in people who use snuff, it's also called as snuff dippers cancer. So it can occur in any mucosa like oral cavity, larynx, or esophagus. Intraorally, the sites where the tobacco is placed chronically, all those sites can be affected, especially buccal mucosa, gingiva, or alveolar ridge can be affected, and it's common in males in their sixth to seventh decade. And people who have the habit of tobacco chewing are commonly affected. And clinically, we can see that they are seen as exophytic growth with papillary surface. Sometimes they may even have a pebbly surface. And in this case, we can see rugae-like folds with deep clefts. So these are all the clinical features of verrucous carcinoma. Sometimes the deeper structures can also be involved, like the bone, muscle, or even the salivary glands. The regional lymph nodes are usually tender and enlarged. The patients will usually come with a complaint of pain or and difficulty in mastication. Histopathologically, we can see that so this is the normal mucosa. So this is the verrucous carcinoma. So we can see that the verrucous carcinoma exhibit both the exophytic as well as the endophytic component. So we can appreciate that the epithelium here is well differentiated, and it shows a little mitotic activity. The pleomorphism, hyperchromatism are all very minimal. So we need to appreciate that the basement membrane is intact with the presence of intense chronic inflammatory infiltrate in the underlying connective tissue. We can also see that these broad rete ridges, they are described as elephant foot-like rete ridges, and they are seen pushing the connective tissue. In this picture, we can see that there are deep clefts which are filled by parakeratin, and these are called as parakeratin plugging. This is a slide of verrucous carcinoma. So we can see that this is the normal mucosa, the epithelium and the connective tissue appears normal. When we move forward, we can see that there is a exophytic component, and then there is also an endophytic component here. Then when we move to the surface, we can see that there is increase in the keratin layer, and then the rete ridges appear to be broad, and they are seen to be pushing the connective tissue, and then underlying the bulbous rete ridges, there are chronic inflammatory infiltrate. And also it was appreciated that the dysplasia was very minimal. So these are the basic features which differentiate verrucous carcinoma from oral squamous cell carcinoma. So we can see that verrucous carcinoma is slow to grow with less metastatic potential and having a good prognosis, whereas oral squamous cell carcinoma grow rapidly and they have a high metastatic chance, and the prognosis is also very poor. Then histopathologically, we can see that verrucous carcinoma, the epithelium does not show dysplastic features, whereas the epithelium shows high dysplasia in oral squamous cell carcinoma. Then elephant foot-like retiridges and parakeratin plugging is seen in verrucous carcinoma, whereas these are absent in squamous cell carcinoma. Keratin pearls are not seen in verrucous carcinoma, whereas keratin pearls are seen in squamous cell carcinoma. A breach in the basement membrane is usually not seen, or the basement membrane is intact in verrucous carcinoma, whereas a breach in the basement membrane is seen in the squamous cell carcinoma. Then islands of dysplastic epithelium are not seen in the connective tissue in verrucous carcinoma, whereas islands of epithelium seen in the connective tissue show dysplasia in squamous cell carcinoma. So the treatment is conservative surgical excision without radical neck dissection because the metastasis rate is very less, and also the prognosis is good. And it is observed that patients treated with ionizing radiation exhibit anaplastic transformation. Hence, radiotherapy is avoided in these patients. Thank you.